Good afternoon, and welcome to this webcast of the Methodist DeBakey Cardiovascular Journal. I'm Dr. Miguel Quiñones, and the editor-in-chief of the journal. And today's webcast is around the topic of our current issue on the cardiovascular education. I'm joined today by Dr. Nadeen Faza on my left. And Abim is Associate Director of our Cardiovascular Fellowship Program. And together with Dr. Steve Little, who's the director of the program, they put together this issue and have done a wonderful job on it. And this is really a very educational issue. I'm hoping many of you will go to our website and read all of the articles. I'm also joined by Dr. Hyeon-Ju Ali, one of our distinguished fellows, and also was one of the authors for one of the articles in the journal. As we go through the webcast, you may have some questions, and feel free to send them to us. Just text DeBakey to 37607. We'd like to start the webcast with an interview I had a few days ago with Dr. Little. He was not able to join us today. So I met with him for a few minutes, and we'd like to play a little video clip of that interview. Greetings, I'm Mike Quiñones, the editor-in-chief of the DeBakey Cardiovascular Journal, and we're here with Dr. Steve Little, who is the director of our Cardiovascular Fellowship Program. Steve is also a member of the editorial board for the journal, and as hopefully many of you have seen, the current issue is dedicated to cardiovascular education and training. And this is a topic that was suggested by Dr. Little about a year or so ago when we were doing planning of upcoming topics for the journal. So, Steve, I'd like to ask you, what inspired you to throw that particular suggestion? Obviously, you were throwing your own head in the hat because you knew that you were going to be the guest editor together with Dr. Faza on this wonderful issue that had just come up. So what kind of made you feel that we needed to do this in the journal?
So it was a process of discussion at the board level, discussion with you, and first and foremost discussion with Dr. Faza. Nadeen Faza is a brilliant cardiologist and a powerful force in our fellowship program. And we really just sort of looked and said, what are the issues that are relevant in fellowship training today, in cardiovascular medicine training? And we had a sort of a list of things, and it was easy to create a long list because there are a lot of things that are happening. Things that are obviously been influenced by the pandemic and the push to digital learning. And some of it was inevitable even without a pandemic. The interest in tutorials and learning in different ways, that was fundamental for us to understand a little better, for our fellows to have a venue to read about and understand more. But beyond that, it was also how has cardiovascular medicine changed in its content, not just in its delivery. The content has changed. It's not the fellowship that you did or that I did. There is now cardio-obstetrics, cardio-oncology, critical care, all of those fairly newish concepts. They've been around, but now they've been solidified as training focuses, as subspecialty focus, as career paths. And fellows are interested in how does that happen? How do you get trained for that? So these are sort of some of the things that we wanted to touch upon, wearing the fellowship program director hat, but also in a lot of conversation with Dr. Faza. I said, what would be interesting and educational from our perspective, but hopefully for others as well.
And you certainly put together a wonderful issue with a lot of good experts giving their opinions and their expertise and sharing them with the audience. Quick question. Prior to this issue, is there anything out there? I mean, is there, as a program director, do you have like a place you could go to, things that would keep you in some sort of update of what's going on in cardiovascular training? Or was this something that you just have to do by the fly of your pants?
Yeah, that's a good question. So not that I'm aware of in terms of organized in a singular issue that I think has a content theme woven through the entire thing. There are individual excellent papers in JAC, and there are excellent papers supported by the ACC and by ACGME And many of the authors that we ultimately, and very easily I would say, convinced to contribute to this journal had been authors in other works. So these are sort of the reviewed versions. Some are de novo, some are sort of reformatted, condensed versions of their opinion from other sources. But to my knowledge, not in a singular issue that a program director or a fellow or anybody interested in cardiovascular education could go to and fairly quickly be up to date on a lot of novel topics.
Well, I want to take this opportunity to thank you and Nadeen for just putting this issue together. It's really very educational. I hope many of you will go to the webpage of our journal and read it. Thank you, Steve.
Thanks, Mike.
Thank you, Dr. Little. Dr. Little couldn't be with us today. It was a pleasure working him on this issue, and we want to thank all our authors for the insightful reviews, and we learned a lot along the way. I'm very happy that some of the authors could join us today and present some of their work. Unfortunately, some of them could not make it today, so I encourage everyone to go to the journal's website and review the different topics.
So first off, I would like to introduce our team of authors from Johns Hopkins. And Dr. Erin Mikos, our senior author for 2 papers. Thank you so much for your contribution. She is the Associate Director of Preventive Cardiology at Johns Hopkins University School of Medicine. Joining her are her 2 first authors. First, Dr. Anna Minhas. She is the inaugural Cardio-Obstetrics Fellow at Johns Hopkins Hospital. And Dr. Nino Isakatse. She's the esteemed AJ Research Fellow at the Ciccarone Center for Prevention of Cardiovascular Disease. So welcome. We'd like to start off with our first paper, instituting a curriculum for cardio-obstetrics specialty fellowship training. And as to start off our discussion, could you tell us a bit about why cardio-obstetrics is an important topic for subspecialization?
Thank you for having us today. This is my area of interest, a passion that I found during fellowship. And I think as many of us are increasingly appreciating maternal mortality and morbidity continue to rise in the United States, and it is expected that this will continue to be a challenge as the rates of obesity, hypertension, and pre-existing cardiometabolic risk factors increase, and as women with congenital heart disease are getting better care and are able to make it to childbearing age, go through pregnancy and postpartum. So with this increase in the volume of patients with cardiac disease that are going through pregnancy and patients that develop adverse pregnancy outcomes that subsequently have increased risk for cardiovascular disease, there is a need for subspecialty training and also more built-in training into general cardiovascular fellowship as it relates to women with pregnancy complications.
I see. So then for some of us, especially the general cardiology fellows who need to learn more about this very important topic, we all have such different exposures and availability of resources. Do you have any advice for how to augment our exposure and curriculum for cardio-obstetrics also during general fellowship?
Yeah, I'll be honest, Hopkins did not have a cardio-obstetrics training program or even much incorporation in our general fellowship. So this is something that we struggled with too. And I had the pleasure of being our chief fellow this year. So here are some of the things that we've done that other institutions could consider. So as part of some of our lighter rotations, we've built in a cardio-obstetrics clinic that the general fellows rotate through. It happens once a month, and when they're on that rotation, they spend time with us. We also have the fellows rotating through adult congenital heart disease participate in this clinic, since that's about half of our patients that we see here. We've built in some lectures, both from cardiologists and from obstetricians, into our regular noon conference schedule. And then we try as much as we can that when pregnant patients are called for a consult from the cardiology service, that I try to join as the advanced cardio-obstetrics fellow, so to say, provide some education for the general fellows. And I'm very aware that other institutions might not have an established program similar to how it was starting out here. And it will require collaboration. For me, our program director was a huge part of us starting this collaboration with the OB team to allow our fellows to train, but also their fellows to train. So my suggestion for chief fellows and then any fellows that are interested in having a similar pathways to approach their program directors and see if they can help facilitate a connection with the OB service.
That's great. Thank you so much. I've been writing some notes down, try to implement some of the changes you mentioned. That's really great. Speaking of collaborations, could you elaborate a bit about the multidisciplinary approach to cardio-obstetrics? It does seem like this is very important in that field.
I think any field that is building and growing, such as cardio-obstetrics, where such a core part of that field is the research that's being done, is discovering what the pathology is and how to manage the pathology in general, because this is such a new field, inherently requires that anyone training in it appreciate where the evidence lies and what the gaps are. And our suggestion is anyone who is planning to do a clinical cardio-obstetrics training pathway also strongly consider adding a research component. So we have some phenomenal women's health researchers such as Dr. Mikos that are a very strong part of fellows training in women's health related topics. And then the education. Again, this is a new field. There are no COCATS guidelines that exist for cardio-obstetrics training. It is so new that it's not even mentioned in the last iteration of COCATS. So the education, so if let's say your institution does not have a lot that they can offer for education, there's now thankfully ease of communication through online learning and through seminars nationally, and then through larger conferences such as ACC and AHA. So we really feel that all three components, the clinical training, the research, the education, fit together for strong training.
Great, thank you so much. And I'll turn it over to Dr. Faza to discuss the second article.
Thank you so much, Dr. Isakadze and Dr. Mikos. Thank you for your paper on starting a research career in cardiology. Could you share with us some essential steps to success in a research career for fellows in training and early career cardiologists?
Thank you very much. Also, what an exciting journey to start as we're starting building our careers in research and cardiology. And it's really an honor for us to kind of share our core principles of how we look at the mentorship at Johns Hopkins Center for Health, Technology and Innovation, AHA's Assistant Center. And we're blessed to have Erin as our training director and amazing mentors as Seth Martin and Yuvan Commander-Mensah and so forth. So with that, obviously there is not a recipe that fits everyone, but core kind of steps and essential steps are to first identify your passion. So what is what gets you excited as we're thinking about starting our research careers? What is a topic that you are happy to work on and you enjoy thinking about the ideas and so forth? And you may write down multiple ideas and then talk to your trusted peers and think about how you could approach narrowing it down. And subsequently, as a step two, start exploring early on this kind of research ideas with multiple potential mentors. So what I've heard a lot of people say, and I've had this same experience, is initially people will think they have to have a polished research idea, outline the hypothesis and or clinical trial plan before they approach their potential mentor. And actually, when you talk to the mentor, that's where those amazing ideas can be born, with the collaboration and synergy and kind of discussing through brainstorming different ideas. In addition to identifying mentor, it's important to make sure that if that mentor cannot serve as a sponsor, and there is a difference between the mentors and sponsors will help you kind of build your network and can get you connected to the scientific committees or like national organizations where you can network and build further your collaborative network. So sometimes mentors can serve as sponsors, but sometimes you might want to like talk to other people to have that team of people who can be, your research mentors, as well as career and career mentors and sponsors. And then finally, getting published, trying to like write as much as possible, even if it's like in the methods stage, writing the kind of methods papers or viewpoints, and then also like trying grants, like writing grants. Although it's difficult to get the grants in the beginning, it's a great exercise where you learn a lot. So this is kind of a outline of the steps, but of course, Dr. Mikas, if you want to add anything, feel free.
No, I just want to say that, finding a mentor, it's not always the biggest name in the field. That person may not have the bandwidth for you. So, and then junior, mid-career faculty can be excellent mentors. So it's also to understand that it's a two-way street. It's a give and take relationship. It's like a friendship. You can't just approach somebody and say, will you be my mentor, out of the blue? I mean, just like you wouldn't approach someone on the street and say, will you be my friend? It's a little awkward. So it's about getting to know someone and seeing if you have a mutual fit. And then when the relationship is good and it's a mutual fit, that the team will flourish. And, it's not this altruistic thing that mentors are just giving to their mentees. No, it's actually, a two-way street where in the good relationships, I learned so much from my mentees like Nino and Adam. It's rewarding for me. I couldn't have done a lot of my research without the grit and the talent and the inspiration and the hard work of my mentees. So it really is a relationship that evolves over time.
Thank you so much, Dr. Mikos and Dr. Izakadze. Can you please highlight some of the opportunities to obtain funding for research?
Yes, absolutely. And people's research can be supported different ways throughout the career. So while as a fellow, there are opportunities to be funded by the T32 NIH grant or AHA-SFRN fellow. There's also other opportunities of Doris Duke and so forth that you can apply and get the funding for. In terms of as we kind of mature more into kind of early career, there is obviously NIH K awards and also AHA Career Development Award and Doris Duke, Donahue, and so forth. And then as a like kind of more senior cardiologist, there are opportunities for the NIH funding as well as fundings from the like AHA, SFRN, and so forth. In addition to kind of this more traditional funding sources, it's great to explore the opportunities of potentially even industry fundings and industry partnerships, especially for like innovative spaces where there is some ideas in terms of new technology and so forth. Collaborating with industry partners can be amazing, as well as like foundations. So if your area of specific research is in a certain area, there are specific foundations that can support your research. So there is a lot of different opportunities, and trying and kind of writing your proposals, submitting to as many platforms as possible is really key for eventually obtaining research support.
All right. Thank you so much, Dr. Mikos, Dr. Minhas, and Dr. Izakadze for being with us today and for your significant contributions to the edition.
Thank
you.
All right. Next up, we'd like to introduce the CardioNerds team. Dr. Amit Goyal, the co-founder of the CardioNerds, who's an interventional cardiology fellow at the Cleveland Clinic. Dr. Daniel Ambender, who is the other co-founder of the CardioNerds podcast, who's an interventional cardiology fellow at Johns Hopkins. And the first author, Dr. Gurleen Kaur, who is an internal medicine resident at the Brigham's and Women's. Welcome. They have contributed the review on Consume, Contribute, and Create, Succeeding as a Fellow and Educator, which is a very important topic to tackle nowadays. How are you all doing today?
Really good. Thank you so much, Dr. Faza, for the introduction and the invitation to share our paper here with everyone.
All right, a pleasure having you all with us today. Could you please elaborate on the three-pillared approach for succeeding as a learner and educating in the digital era? We can review the slide that you provided with the Consume, Contribute, and Create, and if you can give us a highlight on that, we'd appreciate it.
Yeah, definitely. So these three pillars are based on the core concepts of adult learning theory. So we all are adult learners. We're problem-centered, self-directed, internally motivated, and time-constrained. So digital education has really opened up new ways of knowledge and dissemination. But how do you kind of navigate this scene with traditional resources and balance and integrate it with the new digital opportunities that arise? So the first pillar is to consume. We consume content each and every day as professionals, no matter what level of training. It's in different forms. So it could be traditional, like textbooks and journals and lectures and meetings and conferences. But also there's this integration with digital resources like webinars and podcasts, and even learning on social media like Twitter. So all of these resources need to be specifically guided based on the learner's goals. And the advantages of digital resources in particular is that we can access them whenever, wherever, and however way possible. And then now that the medical community is increasingly adopting podcasts for learning, it's really important to evaluate their effectiveness as an educational tool. And specifically within CardioNerds, we've studied the subscribers of the CardioNerds newsletter, and 89% said that podcasts have had the ability to change their clinical practice. And then the second pillar is to contribute. So while we all learn from listening to podcasts and discussions on social media, it's really important to get actively involved within these communities, because active involvement in any stage really allows for better content mastery as well as professional development. And it all really comes down to improving care for our patients. That's our ultimate goal within medicine. So when we think about contributing or creating, those questions and curiosities can stem from clinical practice. And contribution can be in the traditional sense in terms of research and case reports, but also with digital education. And within CardioNerds, the CardioNerds Case Report series gives the opportunity to residents and fellows who've seen interesting cases to share them on a global platform and disseminate their education to everyone who's going to be able to listen to the podcast. The other way you can contribute is not just in terms of scientific knowledge in cardiology, basic science, and clinical pathologies, but also with the advent of digital media, there's the ability to talk about diversity, equity, and inclusion, and really be able to learn from people that are at different institutions. And specifically within CardioNerds, we have the Narratives in Cardiology series where residents and fellows can come and share their journeys in medicine, but also interview people who are underrepresented in cardiology specifically and learn from their both professional and personal journeys. And then the third pillar, the first was consume, second was contribute. The third one is to create. So when we create, we're thinking about how digital technology is different from traditional. So traditionally, we have a learner and educator. They're two separate things, and it's more top-down learning. But when we have digital communities, there's really this blurring of who the educator and learner is. And there's horizontal communication and learning from everyone, a bi-directional flow of education. And specifically within CardioNerds, the Academy has given the opportunity for medical students, residents, fellows to really come together to create these digital educational products through tutorials, through infographics, through Twitter journal clubs to be able to disseminate and democratize this learning. And what's been really so nice to see is that we have medical students teaching about complex, nuanced cardiology topics like apolipoprotein B and what medications to hold before getting a cath. And it really shows that there's no boundaries to who can be a teacher and who can be an educator.
Thank you so much. That was a great answer. And this has definitely changed the landscape of medical education as we know it. Could you please discuss the caveats of using social media for medical education from your standpoint?
Yeah, so like anything in the digital space, there's always the concern for misinformation and lack of validity. It might not have the content that we see in digital spaces, might not have undergone the same type of peer review as journals or case reports or some of those traditional modalities. While that is a caveat, the one good thing is that it's an open format. Whatever you're putting out there is going to be fact-checked from both learners and content experts who are going to come across this information. But it's still really important to remember that creating content comes with great responsibility. So these caveats are both at the consumer side, but also when you're thinking about contributing and creating. You need to really ensure that you're disseminating high quality material because a lot of people are going to be learning from it. And how to do that, it includes like giving credit to your creators, linking references, tagging content experts that will be able to enrich the discussion if it's on social media. And just like when we give a talk or a learning point during rounds or a lecture or grand rounds, we get feedback from the people in the audience to see if how we're disseminating this information is really getting across. And educating through social media is similar. It's an iterative process of learning and evolving over time in those skills, and really collaborating with peers can be really helpful. Having other people review your educational content that you're going to be putting out there for so many people to see. And then with any information posted online, it's really, really important to protect patient privacy and patient information and not to put anything out there that's going to jeopardize patient privacy.
Thank you so much, and congratulations on being the director of the Cardio Nerds internship. Dr. Goyal and Dr. Ambinder, any advice for fellows who are trying to navigate the digital platform space for medical education?
Thank you so much, Dr. Faza, and I'll add just a couple of comments. First of all, we had to change the title in the middle of the writing process because originally the title that was proposed was How to Succeed as a Fellow, and then we realized halfway through, not in the beginning, I realized halfway through that, oh my gosh, Dr. Kaur is an intern, not a fellow. And so we had to change the title to, How to Succeed as a Learner and an Educator. And I think that speaks to the democratization of roles that is possible in the digital space. And really, I think what we wrote about is that it blurs the boundaries between learners and educators. And that's really important. So, for everyone, just feel empowered. There's a place and a space for you as long as you're engaged. I think secondly, in the flip side of that, at an individual level, there is a real possibility of getting too consumed, right? And there's a constant desire to engage, and there's constant content overload. So the flip side of engaging is to create a time and a space for yourself to disengage and turn the devices off and do something that is, hashtag in real life and it fills your heart. And that was at the individual level. I'll end with at the institutional level. The question I'll pose is, this whole discussion, there's so much involved, right? Is this something that someone can just happen upon and do a good job at and get the most out of? And probably not, right? So at the institutional level, are we preparing our community of practice for the present day future? So really, I think we applaud the efforts of IMED at Beth Israel Deaconess, where they are incorporating a digital curriculum as part of the resident as teacher curriculum. And people who've been doing this for a long time, the Nephrology Social Media Collective, that we've learned a lot from. But really, I think we want to thank Dr. Faza and Dr. Quiñones for inviting us, for giving us the space and this topic, this platform. But really the challenge that we would pose is for the bigger organizations, for training programs and for societies to create curricula and equip our community for using these platforms in the best possible way. And lastly, congratulations to Dr. Kaur for everything she's doing.
Congratulations to Dr. Kaur and Dr. Ambinder. Any final thoughts?
No, I just to echo what Dr. Kaur and what Dr. Goyal has already said, explore and feel free to just try to learn as much as you can on the digital space and just do it with intent, do it with a plan. And if you can create a context where you can consume, create, and contribute in a way that basically meshes with your clinical practice and your professional career, you're going to go a long way. So don't be afraid to jump in, dip a toe in, and see how it goes.
Thank you so much, Dr. Ambinder, Dr. Goyal, and Dr. Kaur for being with us today and for your significant contribution to the issue.
If I can make a comment, and one of the things I really think the digital media offers is that one of the biggest challenges we all have in cardiology is that during training, we are very excited about what we're doing. We're learning, we're soaking everything up. But then we start practicing. And a lot of cardiologists, as they start their life as a practitioner, they may start kind of becoming more set on their ways, learning a little less, going less to the ACC meetings, to the other meetings, even sometimes even isolating themselves from their peers. And 10, 15, 20 years later, they're practicing medicine of 10 years ago. And I think this new digital platform allows the practitioners to stay engaged and to continue to have that passion for what they do and why they went to school, why they went to fellowship. So I think this is an amazing contribution that the digital media has. And as somebody who's been practicing longer than some of you have been in this planet, I can tell you that this is one of the best contributions of the digital media. So congratulations to all of you.
And many thanks also from the fellows as well. So next up, we're going to invite our surgeons to discuss procedural training. We have with us Dr. Kasima Alabri. He is one of our very skilled and trusted surgeons here at Houston Methodist DeBakey Heart and Vascular Center, and his contribution was titled Cardiovascular Surgery, Procedural Training and Evaluation. Thank you so much for joining us.
Thank you so much for inviting me to participate in this important part of this issue. Surgical education is actually my other hobby in addition to cardiac surgery. So thank you so much for the opportunity.
So we wanted to start off with our very first question. As I was reading the article, I was struck by this historical perspective that you provided. So could you tell us a bit about how you compared the cardiothoracic training now and 10 years ago?
Yeah. Well, I mean, the evolution and the change in the training in cardiovascular surgery is actually just to keep up with the field itself. I mean, cardiac surgery training, as any other surgical training, was basically the old model where you have an apprenticeship model where you just spend some time with an expert, copy what he does, and go out to the field and start practicing. But structured program has started in the last 2 decades, and they are even becoming more structures. And in the recent few years, both the most popular North American system, the Canadian and the American system, has moved into milestones and competency-based, where the trainee himself has to follow a certain procedure list and expected competency at each stage of training. So, I mean, that did not change much on the way how people are trained, but those kind of the competencies and the milestone, they kept the sort of a quality check for what the trainee should achieve during the training. And I think the training itself has not changed much, but the driving factor around the field and the diseases themselves are changing dramatically. I mean, in the past, we're dealing probably with wider variety of diseases. We have limited amount of therapies, but I think in the current era and nowadays, we have made a tremendous progress and tremendous changes in the amount of technology and the therapy that we have nowadays. And the patient themselves, I mean, our patients are very smart. They have a wide access to the informations, and they are smart enough to pick the therapies, and they kept pushing for certain kind of therapies, and that has pushed us to learn the new technologies. For example, I mean, in the old days, the way cardiovascular training, it used to be cardiothoracic and vascular, where the cardiac surgeon has to be able to provide all this kind of care. But nowadays, especially in cardiac surgery, I mean, the field itself is very subspecialized, like any other cardiovascular field. If you look at the cardiac surgeon, there are some specialized in aortic, some specialized in heart failure, some specialized in minimally invasive, and some people are specialized in transcatheter. And hence, the training itself has shaped toward that way, So the trainee has to start to think early which direction he wants to take. So these are the changes. I mean, it's mostly driven by the evolution and the innovation in the field itself. So that's what has changed actually in the training culture in the last few years. But the training is the same. It's still being done in the operating room, and the same kind of mentality where you progress the training from the easier task into the most complex task. And I think the ultimate aim is to produce a competent cardiac surgeon that fulfill the society expectation. That's how I look at the training. I've been in the training since 2011, and the curriculums and the objectives are changing, but the core itself, I think, remain the same.
Absolutely. Thank you so much for that, and for hitting on this very important topic of how to incorporate these innovative techniques, et cetera, into this current training platforms. I'm also interested in learning more about what you see as areas for improvement for training in cardiothoracic surgery, and how you think we can achieve them in the next few years.
Yeah, I mean, I think we have done well with training, in the clinical setup, but we have to accommodate the changes. We have to incorporate some adjuvant to enhance the training in cardiac surgery. We have not done very well with simulation and wet lab and courses. Those are very important resources that we should utilize more. I think that the cardiovascular surgical trainee should benefit more than what we are doing from simulation, both for training and for assessment. Assessment, I mean, I've spent some time looking at objective metrics to assess and train cardiovascular training, and the field has a lot to be explored in. I think we have to also overcome the challenges of the checklist and the case logs and the time limitation. And many American programs has moved from the traditional where the cardiovascular training is only 2 years. Now they move to an integrated 6 years where the trainee can focus more on the other sides of cardiovascular training, like they spend enough time in taking care of patients in the intensive care unit, learn imaging technique, learns transcatheter techniques, and all the other, the supplementary resources that make the cardiac surgeon aware about the evolving technologies. And I think the learning process does not end by just doing residency and fellowship. It continues. So the idea of coaching is very important. Mm-hmm. And the most important thing for cardiovascular trainees these days, they should be aware about the new technologies and the fellowships and the transcatheter therapies that taken a lot from the surgical care that we used to provide in the past. I think they should be open to this culture. I think they should move into it. And we have few programs in the country. One of them is here at Houston Methodist, where the surgical training get really good exposure to transcatheter and minimally invasive approach to cardiac surgery. And I think the country needs more of those programs, and they are coming year after year. So these are some of the challenges and how to tackle them in the future.
Great, thank you so much, and thanks for joining us during your busy day.
No worries, thank you so much.
Thank you. Next up, we'd like to welcome Dr. Ann Gage. Dr. Gage is an interventional cardiologist and a cardiac critical care cardiologist as well at the Centennial Medical Center in Nashville. She's the lead author on the review entitled Cardiac Critical Care, The Evolution of a Novel Subspecialty. Hi, Dr. Gage.
Hi there. Thank you so much for having me, Dr. Faza. It's good to see you.
Pleasure having you with us. It's exciting that you're both an interventional cardiologist and a critical care cardiologist. Can you educate us a little bit more about the pathway to cardiac critical care training?
Sure, absolutely. So this has been a pathway that more trainees are seeking out over the past 5 to 10 years. there really are two accepted ways currently for training in cardiology and in critical care. The first of these is to do 3 years of a general cardiology fellowship, as almost all of us here have done, and to do a 2-year critical care medicine program through a home critical care department. That's the same as anyone who is internal medicine trained and wanted to go into critical care medicine. You could pursue that pathway through that. So that's 2 years of general critical care medicine. What is open to cardiologists through the ABIM is that anyone who has completed a PGY 6 year of training, so for us that would be 3 years of internal medicine followed by 3 years of general cardiology, you can pursue a PGY 7 year where you do solely dedicated critical care. And so that's the critical care, a traditional critical care medicine fellowship, but condensed into 12 months. After that, if you've done that 7-year pathway, you're able to participate in or to take the ABIM critical care medicine boards. So both, that's the pathway that's specific to cardiologists. So the 7-year pathway, and then you can sit for boards and be a board certified critical care medicine provider also. And that would be the same as if you had done internal medicine and the 2-year critical care medicine fellowship. Both of those allow you to get to board certification in critical care medicine.
Thank you. Thank you so much. And what is the skill set that cardiologists can acquire by undergoing dedicated cardiac critical care training, in your opinion?
Sure. So I think that critical care cardiology is appealing because it probably allows you to focus your skill set in 3 additional ways. I think one of those is through refinement of cardiovascular skills that you may not have been exposed to during a general cardiology fellowship. So I think that that's things that include perioperative management, so pre-op and post-op management of our CV surgery patients. It gives us the opportunity to have more training in mechanical circulatory support, especially in the post-cardiotomy patients or in our general cardiogenic shock patient population on the cardiology side. I also think that during most critical care fellowships, people will have more exposure to advanced heart failure. So the first thing that I think it allows is some more deep dive into cardiovascular training that is pertinent on the critical care side. I think then there's the second component, which is the internal medicine and critical care side of things. That's a general refresher on internal medicine. And so many of us who've done cardiology have been removed from general internal medicine for at least 3 years. This allows us to revisit and continue to hone our expertise in ARDS management, sepsis management, acute renal failure, renal replacement therapies, infectious disease. And then certainly, I think a big part of this training is the acquisition of airway management skills, from intubation through ventilator management to knowledge of how to extubate a patient and deal with their hypoxemic respiratory failure throughout all stages of that disease process. And then I think probably the third thing that a critical care fellowship provides is ICU specific skills. What does that mean? I think that is the opportunity to learn about nutrition in the ICU setting, to talk about infection prevention, quality improvement, things that are unique to the critical care setting that you certainly wouldn't have necessarily delved deep into as an internal medicine resident or as a cardiology fellow.
Thank you so much for highlighting this exciting and novel subspecialty. And I agree, more and more fellows are considering this subspecialty. And I feel like during the COVID times, when cardiologists had to go and be in the ICU, is when we realized that additional skill set that helps us be in that intensive care setting. So thank you so much for highlighting this and being with us today.
Of course, thank you.
Thank you.
Next, I'd like to discuss our very important paper on diversity, equity, inclusion, and belonging in cardiovascular disease fellowship training. Our senior author, Dr. Noshin Reza, could not join us today, but we did get a chance to interview her, so I'd like to introduce her. She is the assistant professor and the assistant program director at UPenn, and here is our interview that we were able to produce prior to this session. giving us some time out of your very busy day. I wanted to start off with our first question. As we read your article titled "The Diversity, Equity, Inclusion, and Belonging in Cardiovascular Disease Fellowship Training," I wanted to start off with this question: what are the merits of diversity in cardiology workforce as well as the training programs?
Yes, well, first of all, Dr. Ali, thank you so much for the invitation to join you today and to contribute to this fantastic issue of the journal, addressing many important topics in cardiology education and cardiovascular fellowship training. So congratulations on a fantastic issue. So yes, regarding your question about the merits of the diversity cardiology workforce and training programs, this is a really important question, comes up very frequently when we have these discussions. And in our review article, Dr. Belinda and I specifically outlined the points with regards to why this is such an important issue. So in around 2004, the Institute of Medicine issued a landmark report unequivocally stating that diversity in the healthcare workforce is critical to improving the United States healthcare system. And actually last year in the Journal of the American Heart Association, many prominent cardiologists, including Dr. Quinn Capers, Dr. Amber Johnson, Katie Berlacher, and Pam Douglas, published a summary of the evidence base that really supports what Dr. Belinda and I talk about in our review article, really the merits of this diverse cardiovascular workforce and training. And we summarize these points in the introductory part of our review, and I'll just briefly summarize them here again. So we talk about the merits of diversity, including number one, improved clinical care, as minoritized individuals are more likely to receive standard of care and follow medical advice when treated by racially or ethnically concordant physicians. Number two, greater access to care in underserved communities, as we know that underrepresented minority physicians are more likely to choose to care for historically excluded populations and areas. Number three, enhanced cultural competence, as we know that non-URM physicians who are working in diverse settings become better equipped to care for diverse populations. And number four, improved research quality, as we've learned from other industries and now we're learning within medicine as well, as diverse research teams broaden the scope for research questions, priorities, and participant enrollment.
Absolutely. And I think that that very first point that you mentioned particularly hits home as I, listen to, for example, my parents and their experience going through the medical care as well. And, as we think about how to achieve these goals, I'm wondering if you could also talk about some of the challenges encountered by women and underrepresented minorities in cardiology.
Yes, absolutely. This has been part of my own research program that I'm trying to really benchmark and categorize the data with regards to the challenges that these groups face. And we summarize them in our review article as well, sort of towards the middle portion of the review, and I'll summarize here. So there are several challenges to creating and sustaining a diverse and inclusive cardiovascular workforce. Some of these challenges include negative perceptions of the culture of cardiology, a lack of role models and structured mentorship, biased recruitment practices, and slow adoption of these evidence-based merits of diversity that we just talked about. We have survey evidence from internal medicine residents, for example, that shows that the perception of cardiology as a field overall is actually quite negative with regards to adverse job conditions, interference with family life, and lack of diversity. And those of us who work and love the field of cardiology are obviously trying to work very hard to prove those perceptions wrong. Both women and underrepresented and minoritized individuals who pursued cardiology do contend with inequities in compensation, access to career advancement opportunities and growth opportunities. And this can certainly be a challenge and a deterrent for people considering careers in cardiology. And for women, additionally, inadequate support for childbearing, caregiving, and for generally growing their families is an additional relevant concern. And specifically for underrepresented individuals, microaggressions, bias, discrimination, and racism really contribute to hostile work environments. So a lot of these barriers are intersectional and affect women, underrepresented individuals, all folks together. And again, we are, as a field, working towards changes systematically in the way that we practice, train and recruit individuals and retain individuals in their eventual practice setting.
Thank you so much, Dr. Reza. And I want to congratulate our future chief, fellow Dr. Ali, on leading a review on the effect of COVID-19 on cardiovascular training and lessons learned. Dr. Ali, I know you trained during the COVID era. Please share your thoughts about how COVID has changed the face of medical education and cardiology training.
And thank you, Dr. Faza, for giving me the opportunity to write a review that's so near and dear to my heart. As we all know, of course, during the pandemic, we all faced challenges with training. With the social distancing precautions, I think cardiology was one of those fields that were particularly affected. Whether it's a hands-on procedural training, the importance of bedside rounds and large gatherings that we were all used to in in-person conferences. So in sort of discussion of this, I thought it was important to conceptualize training in these 4 cornerstones of cardiovascular training. And for each of them, I think we've seen such innovation within our special subspecialty and specialty to try to accommodate and maintain the excellence of training. First off, with the core content education, we saw quite a bit of virtual conferences, telemedicine playing a key role in interviewing our patients, whether it was outpatient and sometimes even for inpatients. And with that, we did also see some challenges: the Zoom fatigue, the variable quality of internet connection, or difficulty hearing multiple people speaking at the same time. And the Zoom fatigue, I think, with regards to this, there have been many different solutions. Some of which I wanted to share, live polls, for example, during conferences, engaging our audience of what their thoughts are on a particular case, allowing the audience to control the mouse and try to participate in this way. And there's been even some, I think, additional literature that has come out, particularly, for example, looking at the test scores for medical students. Are we actually meeting their goals in education? And what we have seen so far is that virtual education is a feasible concept. In fact, some of these medical students that in this study performed even better with virtual education. However, we do see across the board with the trainees that they are less satisfied not having this sort of in-person, of course, I think connection that is, I think, fundamental in core content education. Secondly, with regards to procedural training, I think for this, we really have to thank the ACC Fit Leadership Council. They have done a fantastic job in taking a national poll to get a sense of how the trainees were really affected during this time. And we saw that up to even 70%, 75% of fellows had fewer echoes to read, to perform, and catheterizations. And in this era, simulation-based training became an important tool as well. Of course, unfortunately, this is not an option for all of our fellows. That is a very precious resource that's not available everywhere. But having said this, simulation-based training has been shown to be very helpful, that they can achieve similar levels of competency as well. So this is, I think, an important area for future research, as well as, I think, resource dedication. Thirdly, with regards to career development, many of our fellows ended up having to cancel conferences, even their own in-person presentations of their research, which are important places, I think, for us to develop those skills, but also make those networks. And for this, again, I think we have a lot of our societies to thank. ACC, for example, held virtual career fairs. And for me, that was an important place to connect with the attendings, but definitely with other fellows who had similar interests. And even now, as I'm looking to apply for my subspecialty fellowship in heart failure, those networks with other fellows have been really important. And finally, one of my dear topics is on well-being, and I think that there were a lot of threats, if you will, from the pandemic with regards to this, where there was limited availability of PPE, certainly at the beginning. But I have to say, going through residency and at Brown and fellowship here, I've been really inspired by the program leadership, that they can be such advocates for us and serve as, I think, role models for us to be advocates for each other. So all in all, it was a difficult time, but the innovation and I think the resilience we've seen in our field it has been really great. So thank you.
Thank you so much, Dr. Ali, for a fantastic and insightful review on the effects of COVID-19 on training. I want to thank all the authors who could be with us today, and I also wanted to thank the authors who could not make it today, Dr. Stokes and Dr. Berlacher on the review, The Science of Learning and Art of Education in Cardiology Fellowship, and Dr. Sinha and Dr. Roy on the review on imaging, new frontiers in vascular training.
So this gives an opportunity for us to encourage everybody to go to our website and read all of these articles. There's a lot of education in all of them. I want to make a comment. I'm delighted with Dr. Raza wrote and also discussed the diversity issue and women in cardiology. And actually, the American College of Cardiology have been very, very interested in this particular topic. And although the number of women in cardiology and percent-wise has improved, we're still not there. I'm just delighted to see that so many of the experts, writers, and authors on this issue are women. When I trained in cardiology, none of you had been born. And there were probably about 3 or 4 or maybe 5 women cardiologists in the nation back then. One of them actually was my mentor as a resident and actually helped me find my fellowship position. So I was extremely lucky that I was privileged to have one very bright woman as my mentor back in days when it was very hard to find one. So I'm delighted that topic came up. As somebody who's been in the educational field for 45 years and have seen the evolution of cardiology, I am deeply worried by one aspect of it, and it affects both men and women. That's the duration of training. Many of our fellows have white hair when they come out. Maybe we can call it premature gray, but the fact of the matter is that they're in their mid to late 30s. And this is something that doesn't seem to have a solution, and I think we need to try to find a solution for that. I'm open to any comments by any of you. But many of you are young, very prominent people. You will be taking positions of authority in the ACC and other societies. And this is an area that really we have to tackle, because everybody wants more training. Imagers want 2 years. The heart failure people have 1, but they will soon want 2. EP now is 2. And all of this gets added to the time in cardiology. And at some point in time, we're going to have to sit back and say, wait a minute, time out. Is this the way to go? Is this fair for the trainees, their spouses, their children, their families, and so on? So I think this is one of our challenges that worries me, and I welcome any comments from any of you, but I think that as we move to the future, we're going to have to tackle this. It cannot continue to be like this. Someday, then the EP guys will want 3 years, because they'll have 20 other new procedures that they feel they need to train, and it just never ends. So we have probably 1 or 2 minutes left, and if any of you want to make any comments on that topic, I will definitely welcome. But I certainly think this is an area that leadership is going to be needed in the near future to start thinking out of the box of how we can improve that. Nadeen, what do you think?
I echo your sentiments, Dr. Q, and I feel like the more subspecialized we become, the more years of training we have to spend, and at some point we have to look at the internal medicine training, that's 3 years, and then the general cardiology training, that's 3 years, and is there any way for us to have to trim some of these general trainings and spend more time doing the subspecialization we're all passionate about. And again, as medicine evolves, as the technologies improve, there's going to be room for more subspecialization, and that's only going to add more years to the training. So thank you for bringing this very important topic up.
Well, I hope I can live a few more years to see some of you get into positions of leadership in the societies and start working with this and start finding some solutions. Again, I want to thank Dr. Faza and Dr. Hyeon-Ju. I hope I said that right.
You did.
And all of you for participating. We have a wonderful webcast. And again, to our audience, thank you for listening to us. And please go to the website and read some of these wonderful articles.